Welcome, y'all. I'm Marri Gebril, and today I'm going to be talking about ADHD, sleep deprivation, and racial disparities in Black youth. ADHD is one of the leading neurodevelopmental conditions in American youth today, causing short attention spans, hyperactivity, and impulsivity, which are also common symptoms of sleep deprivation. As Professor Shear tells us, cognitive performance naturally declines throughout the day during hours of wakefulness, so sleep deprivation causes or just exacerbates said symptoms. And mirroring of these symptoms often cause pediatricians to over and misdiagnose individuals with ADHD instead of sleeping disorder because sleeping is not something that is screened for when diagnosing ADHD, which causes confusion and could cause inappropriate treatment plans that could be harmful for patients. And Black youth are disproportionately impacted by disparities in ADHD diagnosis and treatments, often being punished instead of supported when displaying such symptoms. About 10% of youth ages 3 to 17 have ADHD in America, and it's more common in boys than girls. And 25 to 70% of youth with ADHD experience sleep disturbances such as insomnia, delayed sleep onset, or fragmented sleep cycles. And Black children are often underrepresented in ADHD research. It's predominantly white middle class children, and this misrepresentation in clinical literature contributes to less culturally sensitive and appropriate care, leaving Black youth with ADHD at an elevated risk to go untreated or without effective interventions. This more modern understanding of ADHD began in 1968. However, there was some European research done in 1902, but the one that we know today, it was done in 1968, and it was called hyperkinetic reaction of childhood. But in the 1990s and early 2000s, researchers began to pinpoint inattention, and they combined that with subtypes like ADD, attention deficit disorder, but that's been outdated by ADHD now. And then since then, the understanding of ADHD has significantly evolved, especially in humane regards, as pediatricians begin to consider sleep disturbances, anxiety, and mood disorders that contribute to ADHD. However, the correlation between sleep deprivation and misdiagnosis of ADHD is quite fairly new. And again, although this modern understanding is still fairly new, Black children were rarely included in earlier studies due to segregation and institutional discrimination. Children with ADHD often experience sleep irregularity, as I mentioned before, which places them at a higher risk for various forms of physical, psychological, and behavioral health problems, such as increased impulsivity, emotional dysregulation, depression, anxiety, and poor performance in school. In fact, youth with ADHD accompanied with sleep irregularity are also at a higher risk of self-harm behaviors, and sleep fragmentation bridges the relationship between ADHD and self-harm, which has serious implications, such as higher risk for suicidal rates, which we learned in lecture on the first of this month. So untreated and misrepresented ADHD in Black youth play a hand in upholding the school to prison pipeline, as or misdiagnosed children are more likely to be penalized or face encounters with law enforcement for delinquent or disruptive behaviors rather than supported with appropriate interventions for ADHD. And Black youth with underdiagnosed ADHD are often subjugated to zero tolerance policies in school, contributing to school suspensions, harsher discipline and disciplinary actions, lower academic performance, which place them at a higher risk for dropping out, performing poorly in school, and eventually involvement with the juvenile justice system, unfortunately. And lower income children with ADHD face financial barriers in healthcare, which also impedes accessibility to proper treatment and reduces educational attainment, which can increase demand on mental health and criminal justice systems, meaning that disparities in ADHD care are intensified by poverty. School intervention programs for at-risk youth, cognitive behavioral therapy, and parental training programs have proven to be impactful. However, many of these interventions lack cultural awareness, especially for historically marginalized populations where underfunded schools are located, and they're often attended by Black and brown folk, making these program scheduling inconsistent due to the lack of funding resources, limiting long-term effectiveness. Some of my solutions that I propose is a required use of a shared pediatric sleep measure tool for all ADHD screenings, whether that be self-reported sleep habits, sleep tracking machines, logs, and then I would enforce sleep screening into training of pediatricians, child psychologists, school counselors, and nurses so they can identify what distinguishes sleep deprivation and ADHD to avoid misdiagnosis, and also require documentation of sleep evaluation results before making an ADHD diagnosis. And then I would also partner with public school districts and pediatric care systems to ensure sleep evaluations are incorporated when training staff like I mentioned previously, integrated referral pathways to sleep specialists or behavioral interventionists, and administer trauma-informed care workshops and culturally relative training for staff to ensure that they're equipped to assist children in marginalized populations. The first 2 years, I would request government funding via grants, and I would select 6 schools and 3 pediatric hospitals with high Black youth populations. And from partnership between the two, like counselors, behavior specialists, and pediatricians can work together to evaluate children with ADHD and sleep-deprived symptoms, provide culturally appropriate and trauma-informed care sessions as well. The next 2 years, I plan to measure screening, compliance, and diagnostic outcomes so I can use that data from the previous first 2 years to begin the policy drafting and proposal. And with the help of Medicaid and insurance companies, sleep scholars, and behavior interventionists to mandate sleep screening for ADHD testing. And then in the final 2 years, I would advocate for policy adoption by the American Academy of Pediatrics best practice guideline and have state departments of education and health to regulate said policy. And I would also increase investment in lower income schools to help implement consistent intervention programs for at-risk youth and employ and administer more mental health resources. There are some potential barriers, like the fact that the Trump administration is wanting to get rid of the Department of Education. So that leads states to control standard curriculum and protocol when dealing with these issues. So the practices will not be equal or standard from state to state, and that can cause confusion, coupled with the funding cuts for disadvantaged schools. That'll just lead to less support for at-risk youth and inappropriate treatment. And then on another side, there could be just pushback on a policy itself. I mean, the AAP has high evidence standards for diagnosis, so another requirement may seem as another burden. And even if providers do adopt it, policy takes time to settle in. So new training and protocol needed to abide by policy requires extra hours, specialist training requirements, and money. And that will also lead to less support for the policy itself, but it may also result in a more watered down online modular workshop. Some possible solutions is instead of government funding, I could lean more on private donors, large scale fundraising initiatives, scholarships, and other means of getting that money. And then I would partner with hospitals, school districts, and local state governments to propose a state-by-state pilot model to test the policy's effectiveness. And I would start with the more progressive states, maybe California, New York, Massachusetts, who are more open to adopting this. And then I would use existing centralized training models and build off of it to empower a school staff member who then can train others in their schools. And that's a more immediate approach. For the second one, I would frame required sleep screenings as a child health safety measure, not a federal mandate, similar to vision or hearing checks to change the notion of this being an extra burden. And again, I would start with more progressive states, and I would use virtual consultations via telehealth with sleep experts to follow up with marginalized communities. And I would also tap into actual Black clinicians, educators, and parents to ensure that the training is culturally relevant and effective. My hope by doing this is to improve pediatric practices when screening for ADHD and diagnosing by ruling out primary sleep causes, and that will lessen long-term healthcare costs due to better symptom management. So there's fewer doctor visits, there's fewer co-payments for families. My second hope is that the trauma-informed and culturally appropriate care for Black youth will reduce over and misdiagnosis, and it will improve education about ADHD and sleep deprivation for educators, families, and communities, and create a safer space for Black youth. And it will also hopefully result in fewer behavioral referral suspensions and mislabeling in schools, breaking the bias. Thank you so much.